Hi, my name is Steve Ansell. I am a professor of medicine at Mayo Clinic in Rochester, Minnesota, and I'm honored to be part of the great debates and updates in hematological malignancies, this virtual meeting. My role today is going to be to talk about an approach to immunotherapy-related toxicities. As folks well know, immunotherapies have now become standard practice for us, and immunotherapy-related toxicities are becoming more and more relevant. However, as we kind of start and begin to think about this area, I need to first just disclose that I do receive funding from these companies. This funding goes to my institution for clinical trials, but some of these are pertinent to the immunotherapy-related toxicities I will mention. So as we start our discussion today, I think it's important to recognize that we need to just be cognizant of what exactly we're trying to achieve when we're actually doing immunotherapy. So I think as the first step, we need to say what really constitutes an effective T-cell response in various diseases, in this case, specifically lymphoma, because this is our goal and what we're trying to achieve. But as we do that, as we'll discuss later, there are toxicities and side effects that are going to be relevant because of what we're doing to the T-cell response. So shown here is an antigen presenting cell, which you can see the APC on the left, and a T cell, and these two are interacting together. The first thing that is important to know is that antigens will be presented in the context of MHC molecules and will engage with a T cell receptor and provide a first signature, a first signal. And this is an antigen recognition signal. And I think the second thing to know is that at the same time, a second signal needs to be provided. This is a co-stimulatory signal, typically provided through CD28, various B7-1, B7-2 molecules will provide that signal, and that will result in an activated T cell. And an effective response, as shown on the right, is really defined by four components. Firstly, that antigen was well recognized. Secondly, the T cell was activated in an appropriate fashion. The cells then expanded and persisted and could actually target the antigen of interest, but also that immunological memory remains at the end of that effective response to whatever antigen was presented. Sometimes that doesn't happen, and the reason for that is that there are a variety of other barriers and mechanisms that can cause the T cells to become anergic. The first is shown in the top panel. You can see that instead of receiving a positive activating signal, you instead received a co-inhibitory signal through an inhibitory receptor, and that results in downregulation of the T cell response. Also, what can happen, as shown in the bottom panel, is there is no second signal, and in which case cells can become apoptotic and anergic and unresponsive. So again, if we think of this in the context of lymphoma, the first thing to note in the top panel is really, as we discussed, what constitutes T cell activation is that first signal followed by a second signal. What constitutes T cell inhibition is a negative signal shown there through PD-1 or via PD-L1 signaling or through CTLA-4. But there are other mechanisms as shown in the top right, which can also impact that, and that is the role of macrophages, Treg cells, cytokines, all of which may dampen down an effective immune response. Shown in the bottom panel is what we'll be talking about today, and that is there are now multiple strategies in place to overcome this immune dysfunction, to prevent the inhibitory signals, promote T cell engagement with the target, and also then have macrophages brought into the mix to actually target the malignancy. So I'm going to talk about 4 to 5 different strategies that are being used as therapies to treat patients immunologically. And the reason I'm going to do that is I will then, in the second half of the talk about the potential toxicities that come from each of these strategies. So the first strategy is one that many folks are very familiar with. This is the use of antibodies to target immune checkpoints. So again, shown right in the center is the MHC T cell interaction. Remember, we said just to the right of that is the CD28 signaling, which is the typical second signal. But you can see a variety of other either positive signals on the right or negative signals on the left. And so immune checkpoint therapy can either block the negative signal or provide additional stimulation through the positive signal to prevent the immune cells from being shut down. So that is a strategy that's often used. PD-1 blockade is a very good example of that. Second strategy is to overcome the problem with engagement with the malignant cells. So many times MHC molecules are actually downregulated on tumors. And because of that, there is not a very good engagement with the T cell receptor, and hence the tumor is not really visible to the immune system. One way to get around that is to actually then utilize a chimeric antigen receptor. In other words, you're taking an antibody, you're putting that onto effectively a T cell receptor, and promoting attachment of the tumor and the T cells, the chimeric antigen receptor T cells, and providing an automatic second signal. This is really, in essence, what CAR T cells do, forcing T cell engagement and T cell activation and further expansion. A further way in which this is done is utilizing bispecific antibodies or other molecules such as BiTE molecules. Data shown here is from blinatumomab, a B-cell engaging molecule. And as you can see, it's really just a very small molecule utilizing the antibody binding domains from a B-cell and a T-cell antibody to bring B-cells and T-cells into very close proximity. And when that happens, that then results in T-cell activation and the cytotoxic T-cell inducing apoptosis of the malignant cell. But again, recognizing that as we activate T cells, there are going to be effects that we will talk about in just a minute. And a further strategy that's important is the utilization of macrophages to actually target tumors. So shown here is a macrophage in blue. You can see the tumor cell in red. Tumor cells will often express proteins on them that induce an eat me signal, but often will overexpress CD47, which also provides a don't eat me signal. When it does that, the macrophage will actually not very effectively phagocytose tumor cells. If you block the don't eat me signal, that results in much more effective phagocytosis. And in fact, aside from just eating the tumor, there can be further antigen presentation like we spoke about. And as shown in panels E and F, you can see then T cell activation and a further T cell response in conjunction with the macrophage response. And a final strategy that we will talk about is if you have T cells that are present within the tumor or presence that are targeting the tumor, you can actually change the phenotype of those T cells using small molecule inhibitors. And we'll talk about BTK inhibitors and PI3 kinase inhibitors. But what I want to specifically highlight here is a BTK inhibitor. As you can see at the bottom, this targets BTK, which is highly relevant in B cells. But there is also binding to ITK, which is predominantly found in T cells. And this changes the T cell phenotype from a more inhibitory Th2 type phenotype to a more pro-targeting of the tumor type Th1 T cell. So as we think about immunologically related toxicities, small molecule inhibitors can have a change in the phenotype of T cells and hence deliver a T cell effect, which can be quite profound and therefore also induce a lot of immunological toxicity. So as we think about this, very important to recognize that when we do treatments that actually promote the immune response, we are not purely having an effect on the tumor-directed T cells. We have an effect on all T cells. So shown here, particularly in the red, yellow, and green, are various clones, if you like, of T cells that are activated in response to something that is such as a tumor antigen. But also, as seen in the bottom in the purple, are other autoreactive clones which can be activated. So when you either block inhibitory signals, promote activation, change the phenotype, there will be an effect on all of those cells, and hence the side effects can also be seen in the patient at the same time as the beneficial effects that you've achieved as you've activated the immune response. And the typical thing we want to try and create a balance in is sufficient tumor control and minimizing autoimmunity and other T cell non-specific effects. Firstly, as we start off, we need to remember that aside from the effects that we will have directly on the immune system, the actual therapies that we give will have an effect. So as we're thinking particularly of strategy number 1, which was to provide immune checkpoint blockade using a monoclonal antibody, you can see that depending on the type of antibody you're using and the amount of human versus mouse or murine products that are present within the antibody, the degree of immunogenicity that is developed specific to the antibody can vary greatly. So this can be true for the monoclonal antibodies, but this can also be true for CAR T cells. When we're thinking about immune checkpoint antibodies, we need to recognize that almost every organ in the body can be affected by the potential side effects from this treatment. And you can see here that whether it be the eyes, the brain, the lungs, all of these can be affected. The initial thinking was that this could be specific to areas where there is antigen exposure, like the skin or lungs or wherever. But I think as we've learned over time, virtually any organ can be affected. Timing of when this happens also differs, and I think this is important as we think about exactly how to identify toxicities. You can see that many times skin and bowel and liver are often early, and then pneumonitis, nephritis, and endocrinopathies are later. So as we now change our focus a little bit from monoclonal antibodies to chimeric antigen receptors, I want to highlight the potential side effects associated with this agent. So again, there are multiple different toxicities which can be precipitated. You can see at the bottom the allergic anaphylactic reactions just from the foreignness of the chimeric antigen receptor, the potential insertional oncogenesis you see at the top left, and then cytokine release, neurological toxicity I'll discuss in the next slide. But one additional thing important to recognize is the on-target off-tumor toxicity. In other words, we're targeting malignant B cells in the case of a CD19 CAR, but that will also deplete all B cells, resulting in B cell aplasia. So cytokine release syndrome and neurotoxicity are two of the common side effects with CAR T cells. Just want to highlight here that the mechanisms are a little different. The what we understand about neurotoxicity has to do with endothelial changes and migration of both proteins and cells across the blood-brain barrier. And in the inflammatory cytokine release syndrome type process, an IL-6 mediated mechanism is dominant, but this can also engage macrophages, which again is important for the hemophagocytic syndrome, which we can see in some patients. This just highlights the different times in which this can occur. You can see on the panel A on the left at the top, if you look at the blue line, that's when the fever in this particular patient developed, and you can see that was within the first day, persisted until about day 5. The arrows show the doses of tocilizumab that were given, and then it subsequently came down. But right below it, you can see in panel B is the neurotoxicity, and that was predominantly at day 5 when the patient can no longer write her name. And then you can see that the patient benefited substantially in panel C. So highlighted in this image on the right is just the importance of monitoring for CAR T cell toxicity. Cytokine release syndrome on the left, neurotoxicity in the middle, and hemophagocytic syndrome, as you can see on the right. Important to understand the grade and then respond in an appropriate fashion. This just highlights some consensus grading on the left for cytokine release syndrome, on the right, neurotoxicity. There's some differences sometimes between exactly which scales are used, but important to be cognizant of this, anticipating this, and responding either with tocilizumab or IL-6 directed therapy in the case of cytokine release syndrome, or steroids in the case of neurotoxicity. Third issue that we just need to discuss are small molecule side effects. So small molecule inhibitors, I'm going to show you some data here with PI3 kinase inhibitors. I'll show you in a second some additional data on BTK inhibitors. You'll know that in this case, adalimumab, a PI3 kinase inhibitor, diarrhea was a significant toxicity. And that can either be early within the first 2 or 3 months, or later around 8 to 9 months. And important to differentiate this from infectious causes, but important also to stop the drug, give steroids if needed, because again, the T cell function is being changed by this PI3 kinase inhibitor, and that's generating a significant amount of toxicity because of T cell effects. Similar kinds of effects can happen with BTK inhibitors. I showed you a slide for ITK effects from BTK inhibitors. I particularly want you to draw your attention to panels E to H, and those are side effects related to the immune system. You can see that in this case, we're looking at zanubrutinib compared to ibrutinib in the ASPEN study that was a Waldenstrom's trial. But you can see differing effects on neutropenia and yet different effects again on the rates of pneumonia, of all infections, and on effects in diarrhea. Again, you would see this is actually in a sizable percentage of patients. So these are things that one need to anticipate and treat. Finally, we want to talk about toxicities from CD47-directed therapy. So this is treatment that we would specifically targeting the macrophages. The goal here is to activate the macrophages, promote phagocytosis. So on the top left panel, you can see a flow cytometry analysis of calreticulin and CD47 on cancer cells. So this is on lymphoma cells. And you can see calreticulin is a eat me signal. And as cells become older, or as cells actually then become maybe virally infected or tumor cells, they may express more calreticulin, giving the macrophage system an eat me signal. However, tumor cells have worked out how to survive by providing at the same time a CD47 signal, which is the don't eat me signal. So when the balance between don't eat me and eat me favors the don't eat me, the cells are then kind of just let go by the macrophage cells. The reason this is important is shown on the top right. And you can see that other cells as they age may provide additional eat me signals or don't eat me signals. And so you can see that binding to red cells as they age increases, and you can see an anti-CD47 antibody that blocks the don't eat me signal, promotes potential destruction and removal of red cells. And that's what we see across the bottom two trials here, either of a CD47 antibody or a blocking of the receptor with SERP alpha blocking antibody. And you can see effects on red cells on the bottom left and platelets on the bottom right. So with the CD47 antibodies, often there's a steep decline in the hemoglobin with an increase in reticulocytes as the old red cells are removed. Similarly, on the bottom right, you can see that platelets may drop quite significant with the SERP alpha antibody as the older platelets are taken out of circulation. So we take all of that together and say, how does this impact your practice? What I hope you've heard me say is that there are multiple strategies. I presented 5 of them, where everything is being done from blocking immune checkpoints signaling using antibodies, CAR T cells, and bispecific antibodies in promoting engagement of T cells with the tumor, additional treatments to change the phenotype of T cells with small molecules such as BTK inhibitors or PI3 kinase inhibitors, and then finally strategies to engage the macrophages to target the tumor, each of them with unique side effects. So as we bring that to practice and say, how would this pertain to my practice and how I should manage patients? I think if we start with the blue circle that you see in this image, really important to monitor for potential side effects. Important to be aware of side effects with each of these agents as we use them, and engage with our colleagues who may be more expert, neurologists, cardiologists, endocrinologists, to help us to monitor. Many times there may be strategies to in fact prevent some of these side effects. For example, the use of potential preemptive steroids or tocilizumab in CAR T cell approaches as patients become more susceptible to the treatment. Furthermore, important that we have regular monitoring, so hence the anticipating, particularly as you go through treatment with each of the times the patients are evaluated, testing using neurotoxicity as an example. If one is not careful, you may miss the neurotoxicity at an early stage, and important to anticipate that as best possible. Again, the comparison in the detection between the baseline and where we are in the disease course and the treatment course to be able to work out what of this is toxicity versus what of this is disease progression. And then finally, really important to treat and to anticipate and treat early, the use of tocilizumab, IL-6 directed therapy, steroid treatments, withdrawing of the drug, monitoring for a response, all of those are really important in the management of patients. So with all of that, really important for us to recognize that we have unbelievable opportunities to treat people with immunotherapy on the one hand, but potential toxicities to be aware of on the other. And most important is to anticipate and intervene early to obtain the best result for patients possible. So with that, I'll end. I want to thank you for your time and attention, and happy to take any questions if necessary.